Welcome back to the deep dive. Today we're getting into something technical, but incredibly important.
We are.
It's a topic in medicine that could really shift how we manage breast cancer.
A genuine paradigm shift.
We're doing a deep dive into how just changing the format of information, not the information itself, can radically improve diagnosis, surgical certainty, and really the outcomes for you or for someone you care about.
That's right. We're looking at research today on something called image-guided large section histopathology, or LFH.
LFH, okay.
And really what we're doing is looking at why the current standard practice is failing and how this new technique creates this single comprehensive map of the disease.
And our sources just lay it all out there, this critical, really frustrating disconnect that exists right now. You've got a radiologist looking at a huge three-dimensional image, like an MRI or a mammogram, and they can see the full shape of the disease.
They see everything.
But then the pathologist gets these tiny, fragmented pieces of that exact same tissue after it's been removed.
Right.
So our mission today is to explain how LFH connects that radiologist's visual map directly to what the pathologist sees under the microscope. It just closes that gap completely.
And that gap is the core problem. I mean, we really have to tackle that first.
Okay.
Just think about it for a second. The diagnosis, the entire treatment plan, whether or not you need another surgery, it all depends on what the pathologist finds in these tiny little samples.
Right.
So if those tiny samples don't accurately reflect the big, complex cancer that the radiologist saw on the scan, the whole foundation of the treatment is, well, it's compromised. We need a way to make sure the sample really shows the full story.
Okay, so let's unpack that. The current standard conventional histopathology, its biggest weakness seems to be this reliance on tiny little sections of tissue.
Exactly.
Right now, a surgeon removes a breast specimen and the pathology lab slices it into these small blocks. They're what, maybe 2.5 by 2.5 centimeters?
At most, yeah.
Yeah.
And that approach creates what the research calls the sampling problem.
The sampling problem.
Even with the most skilled technician, the best intentions, the conventional method only looks at a minuscule fraction of the total tissue that was taken out in, say, a lumpectomy.
And the numbers in the source material, they're astonishing.
They really are.
In a standard workflow, the actual surface area of the tissue that gets analyzed by a pathologist could be as low as 2 to 5%.
2 to 5%.
I mean, we're basing life-altering decisions on analyzing, 5 cents out of every dollar of information that's available?
It forces the pathologist to basically guess, to extrapolate this huge, complex structure from a few tiny windows.
And the sources have this incredible comparison to really show the scale of the problem.
Yes, the 8 by 10 centimeter example.
Right. So for a pretty common large specimen, say 8 by 10 centimeters, to cover that whole area with the old school small section method, you have to process 21 separate little sections. 21 little squares, each one needing to be oriented, labeled, processed, versus just one single massive slide that shows you the whole thing. It's like trying to navigate a new city with a stack of 21 index cards instead of just, one big fold-out map.
And that fragmentation, it just inevitably leads to what they call a geographic miss.
A geographic miss.
If the cancer is multifocal, so it's in a few different spots, or if it's diffuse and it's kind of spreading out, looking at just 2% of the tissue means you're almost certainly going to miss the true boundaries or maybe even other spots of the disease.
So we have an incomplete picture, and that leads directly to the second big limitation, unreliable margin evaluation. So tell us why this lack of clarity at the edges is so critical.
Well, because the margins, the edges of the tissue the surgeon removed, that's what tells you if the surgery worked, if it was curative.
Okay.
And the sources state very plainly that the small section technique makes it really, really hard to reliably assess those margins. Pathologists are just forced to guess, based on these limited, often randomly sampled areas, whether the cancer went all the way to the cut surface.
And the human cost of that uncertainty is just immense.
It is.
We're talking about patients having to go back for more surgery because the first pathology report couldn't say for sure if the margins were clear.
Absolutely. The research is clear on this. This lack of reliability leads to these unacceptably high reoperation rates, re-excisions.
So they have to go back under anesthesia.
Yes. For another surgery to clean up the malignant tissue that was missed the first time, the sources say that in some patient groups, those re-excision rates can get as high as 30%.
30%? That's almost 1 in 3.
Think about that. The trauma, both physical and emotional, 1 in 3 patients potentially going through a second operation that might have been unnecessary if the first diagnostic step hadn't been so fundamentally flawed by this sampling bias.
And that's the frustration, right? We have amazing imaging telling the surgeon exactly where the disease is,
Hmm.
but the pathology standard is still breaking the evidence up into these tiny, unreliable pieces. So, okay, if fragmentation is the problem, the solution has to be unification. How does image-guided large-section histopathology, or LFH, actually work to fix this?
The core principle is exactly that: unification. LFH uses much, much larger paraffin blocks. You can process specimens up to 10 by 8 centimeters.
That's about the size of an index card, maybe a bit bigger.
Right, and the goal isn't just to have a bigger slide, it's about a commitment to processing the entire specimen whole, or at least in large contiguous sections. You're making sure the full surface area the surgeon removed is what the pathologist sees.
But that sounds like a huge logistical hurdle. I mean, if all the labs are set up for these tiny sections, doesn't processing a block that big require totally different equipment? This isn't just a simple swap, is it?
That is a crucial point, and it's the real friction in this whole conversation.
Yes.
LFH is technically demanding.
Okay.
It needs specialized equipment for these massive paraffin blocks. It needs special training for the staff who are doing the sectioning, the staining. It's a very labor-intensive shift from the standard workflow.
So if it's more complex, it costs more, it needs new tech, why is it better? This must be where that correlation piece comes in.
That's it. The correlation is what makes the whole investment worth it. LFH establishes a one-to-one, incredibly accurate morphological correlation between the diagnostic images, the mammogram, the MRI, what the surgeon saw before the operation, and the microscopic findings.
So the pathologist isn't just looking at tissue in a vacuum.
No. They're looking at a tissue map that lines up perfectly with the map the radiologist already made.
The power in that is just. It's
Yeah.
incredible. Now the pathologist can see the boundaries, the ductal spread, the relationship of the entire tumor to the healthy tissue around it, all in the context of that pre-op imaging.
Exactly. The sources show these specific examples where LFH shows the full extent of the cancer in one single view. And when you see that full map, it becomes painfully obvious that relying on those 21 little restricted areas would have completely missed or underestimated the true spread of the disease that you could already see on the imaging.
It effectively gets rid of the guesswork. The old method forces the pathologist to make an educated guess about the most suspicious area. LFH removes the guess and just replaces it with certainty.
And this ability to correlate the 3D information from the imaging back onto this comprehensive 2D pathological slide, it's essential for a true understanding. It lets the 3 key teams, pathology, radiology, and surgery, all work from a common visual reality,
Right.
which is something they really struggle to do when the pathology is all broken up.
Okay, so now we get to the clinical payoff. We've got the mechanism down. What are the tangible benefits that LFH provides for surgery and, most importantly for the patient? This is the magic part.
The first and maybe the most immediate benefit is the dramatic improvement in evaluating the surgical margins.
Right.
Because LFH gives you this comprehensive view of the entire specimen. It allows for a really reliable circumferential surgical margin evaluation that lines up perfectly with the pre-op imaging.
Let's slow down on that term, circumferential margins. For you listening, what does that practically mean, and why is that so hard to do with the small section method?
Circumferential just means all the way around. So we're talking about the top, the bottom, and all 4 sides of the piece of tissue that was removed.
Okay.
With small sections, you're taking little samples from different edges and just hoping they represent the whole margin. They often get disoriented. You can't see the relationship between them.
But LFH?
LFH lets the pathologist see and examine all 4 of those surgical resection margins in a single oriented slice.
Yeah.
It provides spatial certainty that the cancer didn't reach the edge in any direction.
So the goal is simple. Maximize the complete removal of the cancer in the first operation.
That's it.
And this is where we see the drop in residual disease rates and a huge potential reduction in those repeat surgeries.
Precisely. We are talking about reducing, maybe even getting rid of, that devastating 30% re-excision rate. It's a massive, massive gain in patient quality of life and, frankly, in clinical efficiency.
And beyond just the clean margin, LFH seems to play a huge role in communication. We talked about the 3 key players: radiologist, surgeon, pathologist, needing to be on the same page.
LFH is that common page.
Right.
By creating a single large format visual map of the disease, it makes interdisciplinary communication so much better. The image and the tissue findings are literally overlaid, letting the teams work together to define and see the true extent of the tumor and the margin status. Together, in the same room.
It closes the communication gap. So no longer is the surgeon seeing a huge tumor in the breast, and the pathologist is looking at 21 tiny disconnected slides trying to figure out which little piece is the superior anterior margin.
And that shared visual language, it gives you deeper insights. The sources suggest this common map leads to a much better understanding of the breast's actual structure, the ducts, the lobules, the connective tissue, and how the disease spreads through it.
That sounds invaluable.
It elevates the whole discussion from just is the margin positive or negative to how did this specific cancer use the patient's anatomy to spread?
Right. Now, let's go back to logistics and cost. We said earlier that LFH preparation is more complex, it's labor-intensive. So how can the sources argue that it's ultimately less time-consuming and costs less overall?
It's a classic case of looking at the total cost of care, not just the cost of one procedure in a silo.
Oh, okay.
While the initial LFH prep is more expensive in materials, labor, equipment, the sources argue those costs are immediately outweighed by the huge expense of a reoperation.
So you invest more up front to guarantee you get the diagnosis right the first time.
Exactly. Just consider the financial burden of a 30% re-excision rate.
It's huge.
Every repeat surgery needs a second round of operating room time, anesthesia, nursing staff, facility fees. Not to mention the post-op recovery. When LFH can prevent 1 in 3 patients from needing that repeat procedure, the savings just pile up very, very quickly. It stops a diagnostic error from cascading into a major, complex, and costly surgical problem. The total cost per patient journey goes way down.
It completely reframes the definition of efficiency.
It does.
The conventional method is fast pathology, but it leads to slow patient care. LFH is complex pathology that leads to fast patient recovery.
That's a perfect way to summarize it. You're optimizing the entire clinical pathway, not just one step in the lab process.
So to wrap up our deep dive today, image-guided LFH really represents a profound shift.
It does.
It moves breast cancer pathology away from this fragmented, kind of risky sampling toward a comprehensive, unified visualization. It's a single, integrated map that makes sure the pathologist, the radiologist, and the surgeon are all aligned on what the disease really looks like.
And that alignment is the key. That's the main takeaway. The real power isn't just in the size of the slide, but in the necessary integration of the imaging data, the pathology findings, into one single authoritative view. It's about synthesizing different kinds of information to get the most reliable answer.
So what does this all mean for you, the listener? We've seen really compelling data that clinical outcomes, surgical certainty, and even costs can all be drastically improved by just changing the scale and the format of the information shared between specialists. And this raises a pretty important question for you to think about. In what other critical high-stakes fields, outside of medicine, are highly expert teams failing to perform at their best, not because they lack knowledge or tools, but because they have a persistent and, frankly, unnecessary lack of a clear, shared, and comprehensive visual language for complex data? Think about that fragmentation in your own field and what a single, unified map could change.
Something to ponder until our next deep dive.
We'll catch you next time.